You've got to get primary care out of fee-for-service. Nothing good can come from having a primary care doctor have to deal with billing and coding and 7-minute appointments and all that. You've just got to get primary care out of that environment. So using direct primary care is key, even if it's just virtual.
Hey folks, welcome to another episode of Healthy Savings. I'm your host, Sasha Gribov. I'm the co-founder of Milu, and we're joined by Christy Gupton, who is the founder and president of Custom Benefit Solutions. Christy, thanks for coming on today.
Thank you so much. Hi, everyone. This is great, Sasha. I really appreciate being invited here. Thank you.
Absolutely. And Christy, you are not new to the podcast world, right? You've done this before. You have.
Yeah, so I joined the Health Rosetta in 2017. And by 2019, I said to myself, look, I could keep going around and evangelizing this whole thing. But there's so many people that are not ready to hear it. I could go bankrupt, driving myself around talking to people that the light bulb has not gone on for them yet. But it's not that I don't want to have these conversations, but ultimately the decision makers, the buyers, the healthcare buyers that I'm trying to convert, to paying clients, if they're not ready to hear it, then they're going to have to hear it on their time, not my time. And so I just said to myself, I'm going to have to record these conversations and just have them regardless of who's listening, and then replay them digitally whenever the moment is right. And so it has been nice to start to see the marketplace change and grow and start to understand that something needs to happen. And so if I've had a conversation 2 years ago that is relevant finally today, I can, copy and paste the link to that podcast and send it to them, and hopefully they subscribe. If they don't, that's okay. It's really just a platform to help advance the movement, no matter if it's on my time or their time frame. So
that makes sense. I once talked to someone who was they're the CEO of a bunch of big companies. I'd see them repeat the same message over and over and over and over and over to employees. Like, I was like, this is boring. And their perspective was, yeah, but like, that's the only way it gets through. Like if you believe in something enough to stand on the rooftop and shout, you gotta, like, doing it once doesn't matter. It's,
right.
Even if people hear it, they'll forget it. You got to keep going.
I remember whatever behavioral scientist and marketing expert, said that a person has to hear something 7 times before they actually recognize that truth, whatever it is. So yes, I've developed many little taglines over the years. Probably my favorite is all it takes is a good advisor and a little courage. It's a truth to me. I hope it becomes a truth for others, but I think it's pervasive, it applies to so many things, because change takes courage. I don't care what kind of change it is. I mean, I don't think the healthcare purchasers are in any different of an environment, right? They probably do already purchase other things differently than they do healthcare. And if they would apply some of the same purchasing behaviors to the way that they purchase healthcare, that would be super. But at the end of the day, they're still going to need someone, I hope they want someone to step them through the process and sort of like hold their hand and also encourage that summoning up of the courage that they need to embrace the change, whether it's drastic change because they're being forced to, or whether it's methodical change, baby steps, kind of thing. So I think each situation requires a different approach. And unfortunately, I am definitely seeing areas where employers have put off this methodical change. They've just put it off and put it off and put it off and taken the wrong advice, honestly. And now they've backed themselves into a corner. And so they're going to have to move forward with drastic change. And so that needs also a certain type of specialist advisor, trusted advisor to say, I understand, and here are the steps we need to take to get our arms around more change than you might have had in mind. Because cost is such a barrier now, and it's gotten to the crisis stage, right? It's gotten to if we don't make these drastic changes, we are not going to have a health plan, period. So
How have you seen that play out? Like, or have you seen that with groups where, they get their 12%, 15%, 20, 30, whatever it is, increase year on year and year, and they're just like, okay, I'll take the punch, I'll take the punch, I'll take the punch. And is it they get a 40% increase one year and it breaks them, or it just the next 15% breaks them? Like,
that certainly has occurred, no doubt about it. I've even heard, this didn't occur under my watch, but I've even heard of an employer receiving a 100% renewal increase. I mean, crazy, right?
that's nuts.
But I think the more likely scenario is they've been the frog boiling in the pot, right? Or slowly, the heat's been slowly turning up, and finally they realize if they don't jump out of the pot, they're going to boil to death, right? And what has occurred over the seasons of renewal is employees sometimes will have vacated that plan because they don't see the value in it anymore. So they've either gone in a different direction or they've gotten on their spouse's plan. And so, especially in small business, say, private sector business between 20 and 100 lives, I've definitely seen groups more in the service sector. Say, take a construction company. Construction, in my opinion, they are really in danger in this environment because they are not recession-proof businesses in the first place. They're very subject to feeling the pain of inflation, probably more earlier than most. And they have a highly young male workforce. I mean, think about it, Sasha. When you were 20 something, were you like eager to pay $50 a pay period into some health insurance policy that you never intended to use, right? It was always
Right.
some distant risk, right? And you were just like, no, I'm going to spend my money on girls and beer on the weekends and not health insurance premiums. So when you start to have your workforce pull away from your health insurance offer, and all that remains, renewal after renewal after renewal, are the older, more healthcare needy managers and owners. That is a death spiral, honestly. Those chickens come home to roost, and it's occurring, and I've seen it a lot lately.
I hadn't thought about that angle of it. The fact that the cost of the plan goes up and the younger people drop out, and then you're just dealing with a worse population, and then you're going to get a massive increase a year or two down the line. Like that's a very real thing that I'm sure is happening across the board.
Not only a massive increase, but if you finally get around to deciding, oh, okay, maybe we need to try something different. This fully insured world is just leading nowhere. And so maybe we need to look at something in the level funded space. No stop loss carrier is going to take you if you have less than 50% participation on your plan. They're not going to quote that. So then you're left with considering an ICRA, which is not a bad solution. I promote an ICRA solution plenty. But sometimes you back yourself into a corner where that's your only choice.
By the way, just out of interest, are you seeing more people go the ICRA route? Like, is it becoming a thing, or is it still, an occasional interest?
For me personally, I don't see a big uptake of it, but I do see the value in it, and I present it certainly as an option. I think there's some confusion. A lot of people can't keep all the different choices compartmentalized, in their minds
Yep.
and say we could go in this direction or we could go in that direction. Sometimes the lines get blurred, and it takes a lot of communication and a lot of engagement to sift through all those choices. But I support it. I think it's a great solution. I just don't think it's as a high level performing solution as, a self-funded plan where you've got people engaged in their own health, working with a direct primary care doctor, and having some of the lowest unit cost of healthcare options available to them. Because let's face it, if you're using an ICHRA, many people are taking that money and going out into the individual marketplace.
Right.
And that's definitely not where the lowest costs are.
Yeah, that's been, when I first heard about ICHRAs, I got pretty excited. I thought it really could be a big deal. And I still think that it could, these things take a while. It could be 2 decades. But my challenge is I'm in Chicago, and, I go on the marketplace and look it up, and the prices are insane. Couldn't imagine where everybody meets in the middle. And I think it's market by market specific. It might be that in other states, there's just much better options on the individual exchange. And so an employer can contribute less and an employee can still get a good plan. But
again, highly male, highly in their 20s, and not necessarily understanding the value of having healthcare benefits at work. Well, of course, they're getting railroaded by the bucas. And when we start talking about an ICHRA, the actual money that they're spending on a buca plan, which they already don't see the value in, but then when they look at taking that same dollar amount and putting it in an ICHRA, that just doesn't go very far in the individual marketplace. When you've got community rating and all that to deal with. So your young workers are not going to get a very good deal in the individual marketplace because of community rating. If anybody needs an explanation of that.
yeah, can you give it?
Basically, it means that if you take your workforce and divide them up into 3 categories, the oldest, the folks in the middle, and the youngest, the oldest will not pay any more than 3 times the youngest. The youngest are overpaying because the oldest can only pay no more than 3 times the youngest. So it's almost like dividing your workforce into thirds.
And that's how the individual marketplaces work.
Yes.
That makes sense. And then let's go back to the construction company example that you were talking about. Like, what's the answer? If you're the president or owner of this construction company, let's say you got 100 people, you're in the Southeast, you're on a buca plan, and you got your 9% increase. So you're like, okay.
Yeah.
Is the answer immediately go self-funded? Is it start looking at level funded options? Is it start teaching your employees about, being better healthcare consumers? Like where do you start?
Oh, I guess it depends on a lot of different factors. It probably depends on cash flow too, because at least in a level funded arrangement, you don't have these wild, roller coaster. I mean, not that I should really describe self-funding that way, because if you do it right and you create the correct supply chain and the correct plan design, employer-built healthcare instead of insurer-built healthcare, then you may not have these, ups and downs in the weekly funding requests, right? I think it will come out in your engagement with this client / prospect, whoever the group is. It'll come out and you'll determine what their comfort level is, maybe even based on what they've already budgeted for their poorly performing fully insured plan. So, and then again, like I mentioned before, if they have not backed themselves into a very awkward corner where they are desperate to save money. Because let's face it, we're in some challenging economic and inflationary times. So if they're not in a position where they have to cut the healthcare budget, then maybe that's a starting point, and maybe you can start to retool the plan, using construction references. You can rebuild the house and rewire the plan so that it functions more efficiently. Let's add direct primary care in. Let's carve out your PBM to one that's transparent and prefers local independent pharmacies and helps employees navigate to the generic formulary by creating $0 copays for generics, and puts them in close contact with their own personal pharmacist, and have a relationship there. Let's also address musculoskeletal problems. Let's get them virtually in contact with a physical therapist, someone who also works with an orthopedic doctor, and we can address, physical ailments. What's causing you pain? What could possibly put you on an operating table if we're not mindful of how your body? I mean, because let's face it, in the construction world, that they put their whole bodies into their work, and their whole body needs to be functioning properly in order to do their work, right? There's a punch list of about 5 things that you can address pretty easily, even in the very first year of a new supply chain, health plan strategy. And so I think care coordination, it should come first. You should have a nurse navigator, a nurse advocate that knows how to bob and weave and talk to every employee and make sure they know exactly what their plan provides and how to steer them to the right choice for the right situation. And then primary care comes absolutely next. You can't put that anywhere but, in the top 2 parts of the strategic plan. So you've got to get primary care out of fee-for-service. Nothing good can come from having a primary care doctor have to deal with billing and coding and 7-minute appointments and all that. You've just got to get primary care out of that environment. So using direct primary care is key, even if it's just virtual.
I wanted to ask you about that because I know direct primary care is a thing that you're passionate about and you spend a lot of time and effort talking to your groups about. How has that evolved over time? Like, were you talking about DPC 5 years ago and 10 years ago with your groups, or is this a newer thing? And what's the response like from your groups? Because it's not cash on cash. It's not cheap, right? Like you have to. It's an investment.
Sure.
I believe it's like the best investment you could ever make and the best service you could ever offer your employees. Like it's amazing, but it's a decision you got to make.
Absolutely. I started talking about direct primary care in like 2018. So maybe, a year after I joined Health Rosetta, and I started seeing it play out in real life. And so in 2018, I think I met Dr. Shane Purcell that same year because he and I and another advisor got the Free Market Medical Association of the Carolinas chapter going. And so back at that time, we needed a physician, to represent the interests of that chapter. So I met Dr. Shane Purcell of Direct Access MD down in Anderson, South Carolina in 2018. And we've been great colleagues ever since. He wrote a book about DPC and employers. Once I started visiting, like in person, I wanted to see these places for myself. So I would just get in my car and hit the road and go travel and visit all these places. But I also wanted to do that for my clients too, so that I could make a recommendation and say, I've been there. I've met with these folks. I've seen their practice. I've met with, and interacted with their whole staff. And And this gets, the Christy seal of approval, right? So I don't like to make recommendations where I haven't seen it and touched it and felt it. And that's probably why it's taken me a bit longer than others to embrace virtual primary care, but I'm coming around. I know that regionally and geographically speaking, that has to occur, because the brick and mortar direct primary care, while it's growing, it's just not growing in every city at the same time.
Yeah.
You have to be patient and make sure you've got the right situation. If it's face to face, a handshake type of agreement. In the interim, virtual primary care is a perfectly good solution. It just took me a little longer, to come around. But
That makes sense.
yeah.
You know what's cool? I personally think one of the things that has messed up our healthcare system inadvertently is the fact that we used to have all these independent doctors running their own businesses, being entrepreneurs, and now they're swallowed up into big systems. And I'm not I'm not unique. There's a lot of people who have done a lot of thought and research about that. But when you call a big system and you get the customer service line and not the doctor's actual office or a nurse or a PA, it's a totally different experience. I don't know. There might be a change starting to happen. There's DPC on the employer side. There's concierge and direct to consumer in other parts of the world. But I was just with a friend over the weekend who's a primary care doc. He's been working for a major system his whole career. And he's like, hey, I'm thinking about going out on my own. I was like, oh my God, like this is someone who 50 years ago would have been out on their own from day one. And 10 years ago would have never considered it. And now they are. Now they see concierge as, I think, a better approach for them personally than DPC right now, but they're not super familiar with DPC, right? They haven't yet talked to a Cristy who's got employers that will follow her. They haven't talked to a president of a construction company. So I think as those matches start getting made, there could be real magic that starts to happen.
That's what I've always thought ever since I, embraced it myself. And so I have my own direct primary care doctor, and I see the value of it for our little family and for our small business, and every client that I work with, because I have a lot of personal experience. But, you said something that recalled a conversation I just had yesterday with a primary care doc who's currently working in a hospital system. And she said, I come into contact with, say, a complex patient who may have, 3 issues that we need to address. I could totally address them. I know how to do it. I was trained to take care of these needs, but my hospital employer requires me to send them for a consult for this, that, and the other. So now they have 3 new specialists they have to see. It's just a whole labyrinth of complexity.
3 more bills, by the way, at a higher price point.
4 sets of copays. And she said, it's just so unnecessary. And it just makes me feel yucky to practice medicine this way. It shouldn't be this way. But, I got swallowed up into it. And now I have to make the difficult decisions on how to get out of it. And it's not easy because she's signed a non-compete and all kinds of complex arrangements that mean uprooting your family, moving out of town,
which is nuts. Like, what other profession do you need that in? Like, if I'm an engineer and I work for a software engineer, I work for Google, if I want to go work for Facebook, I don't move my family. I log in, I get a new laptop. Like, right. It's a crazy thing.
Exactly. You take your skills, where they can be appreciated. You're not a slave, to some overlord.
Yeah. What struck me about what my friend was saying, he sees, I don't know, 20 plus patients a day. And he's like, I want to spend 40 minutes with a patient. And when I do that, I'm going to spend half the time not talking about medicine. I'm going to talk about their kids. But then, like, when they need to trust me on something, they will. And today, like, a lot of that trust is lost, right? Like, you still trust your doctor probably more than anyone else in society, which is as it should be. But it's not the same. I don't have a physician that I have a personal long-term relationship with, and the fact that you and others are able to go and bring that to employees through their employers, I think is a very cool thing.
Don't worry. I know a DPC in Chicago, fairly new one. I'll make an introduction.
I love it. I love it. I love it. So, where do you think this stuff goes? Like, are you seeing more and more employers go self-funded? Is it less scary now than it was, earlier in your career? Are you seeing more folks have the courage to make a decision, or is it kind of more in the same and you're fighting an uphill battle?
I mean, it would suit me just fine, yes, if there were a lot more employers brave enough to make some serious changes. I think I'm seeing it in a small uptick, but that's probably not representative of consultants that work for bigger consulting houses where their pipelines are more full than mine is. I do see more important conversations happening where employers are starting to consider other options.
And just for everyone watching, where are you located, and what's your geography, and also what's your employer mix? When someone watches this, and if they're nodding along, like what should their situation be to say, hey, like I really need to consider this and I need to talk to Christy or someone else like her?
Sure. I used to say I had a niche, but I don't say that anymore. My client book of business is all over the board, to small, to large, to public, to private. It's kind of all over the board. And I definitely agree. It's another one of my little taglines that we're all somehow being mistreated by the healthcare system at large. It doesn't matter if you're the CEO or the janitor, or if you are in a government plan or an individual plan, or if you're in the Northeast or the Southwest, whatever. In some respect, all over the place, we all have common ground where issues need to be fixed, and we're all receiving poor care in one way or another. If we have time for a little story, I have a good one.
Yeah. Hit me.
Oh man, it's time for my mammogram again, right? And I happen to see a price in my local newspaper. The local hospital owns an imaging clinic, and they advertised a price for a 3D mammogram for $150. That's a good deal. The last 3D mammogram I paid for was around $270, something like that. So I thought, that's a lower, and it's local. So at the last mammogram I got, I traveled about an hour away to get that $270 price, cash price. But this time I thought maybe I'll try the local hospital. Maybe there's something. I'll just give it a try. So I called. I asked all the requisite questions. I wanted to make sure that this fee included the radiology fee, the reading of the mammogram, and the reporting back to my primary care doctor. I asked all those questions. I was satisfied with the answers. And I confirmed once and for all, this is payment in full, right? This cash price, $150. So I made the appointment. And I showed up on the day of my appointment, and so I walked in. They checked me in and updated their system. And there was this little signature pad, right? Little electronic thing with a blue screen and a pen with a cord to it, and another cord connected to the receptionist's computer. Familiar scenario, right?
Yeah.
So she said, okay, if you'll just sign the pad in front of you, we'll get you checked in. And I kind of knew the conversation that was about to occur, but I played dumb just a little bit. So I picked up the pen and sort of acted like I was about to, sign my name. And I looked back up at her and I said, by the way, what am I signing again? She said, oh, it's just your consent so we can treat you today. Or so she might have said, so we can see you today. And I said, oh, okay. And I acted like I was going to sign it again. And I looked back up and I said, what does it actually say? And she said, well, and she struggled a little bit. So I interrupted her and I said, well, do you mind just printing it out for me so I can just read it and make sure I know what I'm signing? And she did. She got out this laminated 2-page document, made a copy for me. And I acted, again, sort of taken aback. And I was like, oh, wow, 2 pages. That's something. I said, well, I'll just go over here so I can read this and make sure I understand what I'm signing. I, of course, located the payment consent, the financial consent on the document, right? Just like Marshall Allen, may he rest in peace. I don't want to start crying. I still can't believe he's gone. But just like Marshall taught us, to find the financial consent and cross through it. Well, so this, you wouldn't believe what the financial consent said. I had it on my desk a few days ago. I would have to sift through it and find it right now. But anyway, and it said something about agreeing to pay anything that my insurance didn't pay. Also, it used words like attorneys and collections agencies and credit rating bureaus and all kinds of other words in this document. So I walked back up to the receptionist desk and I said, this whole section here doesn't apply to me. Can I just cross through it and write, I agree to pay $150, which is what we agreed on, and I'm ready to swipe my card. And I held up my card. I'm ready to swipe my card for the full amount, which is what we agreed on. So this whole payment consent just does not apply to me, and I can't sign this. So can I just cross through it and write what we agreed on? The lady said, oh, no, you can't alter the document or otherwise I can't accept it and you cannot be seen today. And that's when the conversation turned awkward, So she was obviously trained to put it back on me as if it was my problem. And also in the receptionist area, there was this young guy, never really been a consumer of healthcare, I'm sure. And he looked at me and said, ma'am, everyone signs that. And I said, oh, that's interesting. And he goes, it's not interesting. Everyone signs it. Almost like gaslighting me and making me feel belittled because I even asked these questions.
Yeah.
Ultimately, I said that because when they said I could not alter this document that used very punitive language in it that didn't apply to me, language about paying anything insurance doesn't pay, and language about, attorneys and getting sued and being reported to credit bureaus and all that. So ultimately it ended in, I'm sorry, this is just a mistreatment of me as a patient and I'm not going to sign this. So I'm just going to leave and I won't get my mammogram today. And that's that. And so I did. I turned away. I took the copy of the consent with me because I intend to have a few words with the CEO of the hospital. Even when you have all the knowledge that folks like us have about the system, you're still caught up in a wildly, and inappropriately poorly performing system. And being an advocate for yourself is a daily challenge, no matter how much knowledge you have.
And it's just wild how close it came to working, right? Like $150 cash pay price,
right,
all in. That's great, for a 3D mammogram. Like I've looked at mammogram prices. Like that's totally fine, right? Like all it takes is not sending you a bogus financial disclosure that has nothing to do with you.
Right.
By the way, it shouldn't have to do with people on a health plan either.
If the price is the price, then why are you asking me to sign a legal document that binds me to language that doesn't apply to me? And so, yeah, this whole notion around transparency is, I think it's finally starting to get into the minds of patients, because even though I didn't necessarily force this or push this notion to a client group of mine, but I saw an email this week from an employee whose husband went in for a CT and essentially was provided with the same type of document to sign, and he didn't want to sign it. And so he left without his procedure. So now I'm helping him find an independent, radiology practice that doesn't have that kind of language in their consent. And we've essentially, have to sort of reroute care to practices and practitioners who understand how to value patients and in a patient-centric environment. And so I think that the hospital systems and the big practices that are owned by private equity and, those that are more interested in the dollars they can extract from people rather than being patient-centric, I think we're going to start to see patients not only advocate for themselves, but also people that are responsible for the way health plans perform are going to start to ante up and say, let me help you navigate you towards, a better patient experience and a better payment experience for both yourself and the plan. And that's why I mentioned care navigation really early on in the change management landscape, because having that trusted clinical guidance and help them take the steps they need to reroute themselves to a better patient experience and a better payment experience.
We totally agree. I mean, we see this all the time, that when an employee starts to get trust with a nurse that they're working with, it's a total game changer, right?
Mm-hmm.
Like you can reroute care, you can help them find great things, you can help them save a ton of money, you can help their family. It's absolutely huge.
And each encounter is a learning experience, right? So if I didn't have a clinical background, and let's just say, I'm a worker bee at a brewery, it's not necessarily white collar, it's not necessarily blue collar. It's just kind of, I do what I do, and maybe I just don't have a clinical background, and I just need someone to talk me through this overly complex healthcare system and how I can get what I need faster in a happier environment where I'm not being used as a pawn in somebody's sick game, and how I could keep more of my money in my wallet rather than have it taken from me by a poorly performing healthcare system.
Well, Cristy, thanks for coming on the podcast. It's been wonderful having you and talking to you. I hope we can do it again someday soon.
I am always open for that.
Thank you. Take care.
Thanks for listening to Healthy Savings by Milu Health. If you would like more information about any of the topics you have heard today, we would love for you to get in contact with us. Find us on the web at miluhealth.com.